Good afternoon. My name is Shelletta and I'm a third-year College of Pharmacy candidate at the College of Pharmacy, and today I'm going to be presenting my article on clindamycin versus trimethoprim sulmethazole for uncomplicated skin infection. So this article was published March 19, 2015, and it was funded by the National Institute of Allergy and Infectious Disease and the National Center for Advancing Translational Science. So a little bit of background information about this article is that skin and skin structure infections are very common in the ambulatory setting. However, for these infections, there are various antibiotic regimens in the area of community-acquired MRSA that is unclear. So the objective for this article is to basically compare the efficacy of clindamycin versus trimethoprim sulmethazole, also known as Bactrim, for uncomplicated skin infection. So this trial design type included a multi-center prospective randomized double-blind clinical trial of clindamycin versus Bactrim for the treatment of uncomplicated skin infections. The location varied. There were 4 different locations ranging from the University of Chicago Medical Center to the San Francisco General Hospital to the San Francisco Harbor, UCLA, and also Vanderbilt University in Nashville. The inclusions for this article range from ages 6 to 85 years old that were able to complete the informed consent process, and for minors, a parent or guardian who was able to complete the informed consent process. The individuals also must have been willing and able to complete the study protocol, the study-related activities and visits, and also have been diagnosed with an uncomplicated skin and skin soft tissue infection, either cellulitis or an abscess. Evidenced by at least 2 of the following localized signs or symptoms on the skin for at least 24 hours, and those included swelling or induration, localized warmth, purulent draining, tenderness, pain, etc., and also able to take oral antibiotics therapy, either a pill or a suspension form. So the exclusions for this article included were if you had any type of superficial skin infection such as impetigo, body sites that required specialized management such as the perirectal area, the genital area, and hand infections, a human or animal bite at the infection site, a high fever, a recipient of immunosuppressant medications, or the presence of an immunocompromised condition such as diabetes, chronic renal failure, morbid obesity, surgical site or prosthetic device infections, and recipient of antibacterial therapy with anti-staphylococcal activity in the previous 14 days. Patients were ineligible if they lived in long-term care facilities, had cancer or any inflammatory disease that required treatment in the previous 12 months, or had a major surgery in the previous 12 months also. So the subjects for this article included patients that had 2 or more of the following signs or symptoms for 24 hours, which included swelling, induration, localized warmth, purulent drainage, tenderness, and pain. The primary endpoint was the study outcome was clinical cure at the test of cure visit, which was 1 month after the 10-day treatment. And the secondary endpoint for this article was the pre-specified secondary outcomes were cure rates at the end of the treatment and at the 1-month follow-up visit, cure rates in the adults and pediatric population, and cure rates among patients with cellulitis, abscess, or mixed abscess and cellulitis. The follow-up was 1 month after the 10-day treatment of either Bactrim or clindamycin, and the duration of the trial was they received the either clindamycin or the Bactrim for 10 days, and then 1 month after that they had a follow-up visit to make sure that they were cured from this infection. The population for this article, there was a total of 524 patients that were enrolled, 264 in the clindamycin group and 260 in the Bactrim group, and that included 155 children, 160 patients that had an abscess, and 280 patients that had cellulitis, and 82 patients that had a mixed infection defined as at least one abscess lesion and one cellulitis lesion. Patients were stratified into two groups on the basis of characteristics of their infection before randomization. The groups were patients with large abscess or cellulitis, and a group that included patients with a smaller abscess. In the limited abscess stratum included a placebo group. Patients who had a single abscess with a greater diameter up to 5 centimeters were stratified into the limited abscess group. In the other group, all the other patients included those with abscess greater than 5 centimeters in diameter. Clindamycin was given as 250 milligrams tablets 3 times a day daily, and the Bactrim was given as a dose of 160 milligrams of trimethoprim and 800 milligrams of somethazole, administered as 2 single tablets twice a day. Patients randomly were assigned to receive Bactrim were given 2 placebo pills for the midday dose. Pediatric doses were adjusted according to the body weight of the patient, and liquid suspensions were available for pediatric dosaging as well. Um, Pills were overencapsulated to prevent identification of study staff and patients, and the test of clindamycin liquid preparation was masked with using flavoring before to prevent the identification and to improve adherence. For the statistical analysis, the study was designed as a superiority trial with 80% power to detect an absolute difference between the two different groups of 10% point and cure rate in the population that could be evaluated. Assuming a 20% attrition rate, we calculated 524 patients needed to be enrolled. The prospective secondary outcomes were cure rates at the end of treatment and at the 1 month follow-up visit. Cure rates in the adults and pediatric population, and cure rates among patients with cellulitis, abscess, or mixed abscess cellulitis at the test of cure visit, and adverse event rates also. Comparison between groups were performed with the use of the Pearson chi-square test, the Fisher exact test, or an analysis of variant tests as appropriate. All tests were two-sided. And 260 received Bactrim treatment. A total of 52.3% of the patients were males, 53.2% were African Americans, 40.3% were white, and 28.6% were Hispanics. The mean age for this article was 27, and there was a total of 29.6% of the patients were children. That there were no significant demographic differences between the groups. The primary endpoints included no significant difference between treatment groups in either the intent to treat population or the population that could be evaluated, and subgroups consisting of children, adults, or patients with cellulitis, abscess, or mixed abscess cellulitis lesions. The secondary outcomes were cure rate at the end of the treatment at the 1 month follow-up visit, cure rates in the adults and pediatrics population, cure rates among the patients with cellulitis, abscess, or mixed patients with abscess and cellulitis. Adverse events. Overall, the rate of adverse events were similar in clindamycin as to with Bactrim. The most common adverse event with clindamycin and Bactrim were the diarrhea and the nausea and vomiting, the itching and the rash. Also, there was no cases of Clostridium difficile that was associated with diarrhea with the clindamycin. Most adverse events were mild or moderate, and resolved without any type of intervention. The author's conclusion is that they found no significant difference between clindamycin and Bactrim with respect to efficacy. They stated that there could possibly be bias due to the fact that Bactrim has been considered a poor empirical choice for the treatment of cellulitis. Recent data shows that S. pygenes strands may be Bactrim susceptible if the low concentration thiamine agar is used for testing. They also said that their results showing that Bactrim and clindamycin have similar efficacy in patients with cellulitis are consistent with the in vitro data. So the strengths for this article, the fact that it was a double-blind randomized clinical trial accompanied by detailed drug accountability was very good. Also, the populations were ethically and also geographically diverse. The investigation included outpatients, the population in which approximately 95% of skin infections are treated, and thus generalized to a large population. The investigation included both adults and children, which is critical given that skin infections are highly prevalent among persons of all ages. The two antibiotics that were studied were those typically recommended by experts in the area of MRSA um, infections, and also patients were followed up 1 month after therapy was completed, which is a strength in comparison with other studies that lack any type of documented follow up visits. The weaknesses of this study included the fact that this study excluded patients with serious coexisting conditions and the outcomes of skin infections treated with clindamycin and Bactrim in the population with such conditions may differ. Secondly, they only examined two antibiotics for the treatment of either cellulitis or abscess, um, which there could be other antibiotics that could be used for these conditions. Also, the Staphylococcus aureus infections are often recurrent, and 1 month appointment after the treatment may be inadequate for assessing the efficacy of the drug in preventing recurrent diseases because the condition may come back. The dosages of clindamycin and Bactrim for the skin infections are not well defined. Some have suggested using twice the dose we use, whereas others have recommended the same dose that was used in this study. Finally, the proportion of patients that had Staphylococcus aureus isolated that was resistant to clindamycin or Bactrim were relatively low. Given the low prevalence of resistance between the two drugs, could cause treatment failure, which could be unclear. Although there was a trend towards a lower clindamycin cure rate for infections caused by clindamycin-resistant Staphylococcus aureus versus clindamycin susceptible isolates. In conclusion, the investigators of this study found no significant difference between the efficacy of clindamycin and that of Bactrim for the treatment of uncomplicated skin infections, including both cellulitis and abscesses in children and also in adults with fewer or no coexisting conditions. My opinion of this article is that it was a really good article. I thought that the strengths of the article definitely outweighed the weaknesses. To my surprise, I thought that there would have been a much larger difference between using either Bactrim or clindamycin for either cellulitis or any type of abscess. I was very surprised that there was not really any difference, even when it comes to any type of adverse reactions that occurred. Still, there was no difference between the two. So that was my critique of the article, and I just want to say thank you for watching. Bye bye.